Okay, good afternoon, everyone. So welcome to this webinar on the National Digital Health Mission and its potential implications. Today we have got three very esteemed panelists with us, Dr. G.S. Jaya, Dr. Rajiv Joshi, and Ms. Rupa Chakravarti. So without wasting any time, I'll start with the introduction and opening remarks of each of them. So I'll start with Dr. Jaya. Dr. Jaya, please introduce yourself and your opening remarks.
Thank you, Sapten, for inviting me to join this panel and to share my views on this very, very important subject. Very briefly put, I'm a medical doctor who did his MBBS from AIIMS New Delhi. While doing MBBS, I also did a BA with economics, political science, and mathematics. And subsequently, while doing MD pediatrics, I ended up joining the Indian Administrative Service, becoming the first medical doctor ever to join the IAS, which I left 17 years later to become an international civil servant doing intellectual property law. Early years of my IAS, I ended up also doing a law degree from Delhi University. So I have a very rather peculiar background of MBBS, then BA, then LLB. But my life experience is largely of Indian Administrative Service and of the International Civil Service as a professional IPA expert from an international business perspective. My return to India 3 years ago is what prompted me back into medicine, and because of another Amazonian friend of mine who was into health informatics, on Dr. Sashibhushan Bogira, I got introduced to health informatics, and for the last 1 year I have taken a deep dive into health informatics. But interestingly, therefore, my medical background, my intellectual property background, and my love of IT has all come together into this. And in the immediate context, all I can say is that the Joint Parliamentary Committee, which is considering the Personal Data Protection Bill, I ended up making a 50-page note to them on the issues pertaining to what would have remained separate if Disha had become a bill that had been introduced. But since that was left to be merged with the Personal Data Protection Bill, and that never happened, therefore the need for doing what I did. And this note was sent through various routes, in toto through the Digital Health India Association, of which I am the first member of that association, and also through the ICMR AIIMS Genomics Center, of which I am a pro bono advisor, and thirdly through Harvard, who took some excerpts of it in their group, which also sent the same comments. So I wear many hats on the intellectual property front, even on the telehealth front, but I think that is not very relevant in the current context.
Thank you, Dr. Jaya. Now over to Dr. Rajiv Joshi. Please introduce yourself and give your opening remarks.
Good afternoon, everyone. Thank you, Sapten, for inviting me to this session. There is a slide which shows that my interest is our clinical practitioners' views about health data policy. So to introduce briefly myself, I am a pediatrician by profession. I am practicing in my own hospital for last 25 years. My wife is a gynecologist. In addition to that, I have been working in health informatics for the last 25 years. I have been honored to have fellowship in biomedical informatics from US Department of Health in 2008. After that, I have been working with training in health informatics to various people and institutions. I'm also interested deeply into law, and 2 years ago I joined LLB course, which I completed second year. And my deep interest in law as well as medicine and IT brings me here probably. I have known Sapten for the last 10 or 15 years. My concerns about this entire digital health, national digital health mission are plenty. Because of first thing is there is a Director of General Health Services circular of 2014, which requires every doctor to keep digital data for the last 10 years, as well as hard copy data for patient's medical record for 3 years, OPD data for 3 years, medical legal data for 10 years. And as a pediatrician, my concern is if a child is born in my hospital, I have to keep the data for 18 years till he becomes adult. So that is base of paper data. And in addition to that, certain things are being forced on doctors in the form of previously in Disha and now in the form of NDHM. Next slide, please. And when we have several problems with our uh, data. So let's see what is the ground reality of healthcare in India. We have got 1% or less of GDP spent on healthcare. We have got 20% of population treated by government healthcare machinery. 20%, that is only 20% doctors are treated by private sector institutional hospitals. And 60% population is treated by clinics and small nursing homes, which are owned by individual doctors. So these doctors don't use software developed by big software companies because they simply can't afford it. And please remember, 90% of diagnostic services are run by individual consultants such as pathologists, radiologists, etc. So problem is that we don't have good experience with the implementing agencies. The Consumer Protection Act, which is working against doctors, the 90% cases are frivolous. PCPNDT Act, there is harassment, no improvement in sex ratio. Clinical Establishment Act, there are draconian provisions. National Medical Commission was not received properly by IMA, it went on strike. Registration with authorities in like Pune Corporation, we don't have qualified nurses. Fire NOC takes a lot of corrupt practices. Building department, taxes, irregularities are several corrupt practices are there. Now, additional thing is violence against doctors and Pollution Control Act. They are saying that you have to have sewage treatment plant for a hospital having more than 10 beds. Sewage treatment plant costs 10 lakh rupees. In addition, the data protection problems are there. You are negligent if you do not store your records as per Information Technology Act. So in addition to professional negligence, we are going to add Information Technology Act negligence on us. It is wonderful to see a woman cop catching a person and taking him to the custody. But when it is me in that picture being caught by cop, it is not a palatable thing. In addition to this, I have to spend on IT infrastructure, I have to spend on software, I have to spend on trained manpower. There are connectivity issues, so I have to have backup network arrangement. Bandwidth issues are there. And there is no financial return from the expenditure which I am going to make. So what this IT is just now going to add to my clinic is only administrative convenience. I now understand that longitudinal data should be there, your cross-sectional data analysis should be there, but that is at what cost? It should not be at cost of my clinic and my personal liberty. So what we discussed in IMA was IMA will formulate consent on this part. Clinical establishment will prefer to have dual consent from patient. The patient will say, I hereby give consent to record my demographic and medical information in digital format for quick access for administrative purpose, and I do not give consent to transmit my data to healthcare information exchange run by state authority or national authority. They are willing to give copy of the record to the patient in digital format who can upload it to HIV servers. So when I spoke about this in a CELAC conference, the Minister of Health person got agitated and about this act, but fortunately this act was cancelled afterwards. Now for this NDHM, what we are proposing as a solution is that clinician should be called as data collector rather than data fiduciary, and he should not be in a position, as he is not in a position to keep data safe from the possibility of misuse by any person. The primary responsibility of data breach should be with data fiduciary, that is software vendor or internet service provider or network administrator or server or database administrator. Till that time, medical service persons should refrain from participating in any activity related to NDHM. They should hand over data to the patient who may upload it to server. It goes without saying that any person found guilty beyond reasonable doubt should be punished for offence committed. This includes medical persons also. And last point I want to raise is the consent should be one-time affair at the time of registration and not when the person goes to each and every medical faculty or medical facility and every time when he attends the or at encounter. That is what I want to say in introduction. Thank you.
I am a MCH nurse by background, did my public health MPH from JNU and worked in different kind of international NGOs, and I have a understanding and experience working in digital health and from the era of M-Health basically. So and currently I'm working in this space, and yeah. So thank you, Dr. Shupden, to give me this opportunity and having me in this webinar, and to speak on a platform where this kind of eminent people also are talking about. And all of you know that this National Digital Health Mission actually has been launched with a great understanding and expectation, rather I would say. And it's launched in 15th August this year with a to establish a digital ecosystem in our country, and with a health ID, DigiDoctor, health facility registry, and PHR and everything, which we were kind of talking about for quite some period of time in India also. So, but yeah, we will talk more about that. I will mainly talk about the anticipated challenges, etc. later on. Yeah, very nice interaction with you all, and looking forward to the other speakers also.
Okay, thanks, Arupa, for your introduction and opening remarks. So I'll come back to Dr. Jaya. Dr. Jaya, if you can elaborate on your opening statement, exactly what do you think are the potential implications of the NDHM, and particularly this National Health Data Management Policy? How do you look at it? What are the pros and cons? So over to you, Dr. Jaya, please.
Thank you. See, I am commenting it also from not just a legal technical perspective, but also from a bureaucratic perspective. So what I have seen in the government of India, which I've been exposed since 1978, when I joined the Indian Administrative Service, that we make very grandiose policies, starting with our first 5-year plan, down so many 5-year plans, and down the road, therefore, all kinds of missions, whether by this government or that government. The problem arises at the implementation stage. Even at the conceptual stage, there are challenges, and those challenges are particularly severe when you are dealing with things which span both the center and the states, and where states have a major role. So health and education, for example, are areas where states play a major role. So on one side, therefore, in the health context, as Rajiv ji had pointed out, that there have been instructions to hospitals to maintain records for 10 years, paper records for 3 years. And the sad reality is that a hospital, if a patient goes back a second time, whether paper form or electronic form, there is practically nothing in the hospital. So everything is written on the OPD card, and that OPD card is with the patient. And if the patient doesn't come back with his OPD card, the hospital has practically nothing to show. Things are decidedly better in private sector hospitals, but they are also not necessarily anywhere near what one would expect if you are in another country. So I, fortunately, having lived abroad in Switzerland for 25 years, I'm used to a very different system where if you go to a hospital and you want to look at your records, which are 10, 15 years old, then everything can be pulled up at one go at one place and across departments within the hospital. But if you are in India, the chances are that a hospital will not be able to do so, certainly not a government hospital. And that is the context in which the change that is sought is massive. I mean, when we do not have anything functional even at one state level, we are wanting to put in place a system which works across states and at the national level. And this calls for massive amount of planning, but planning needs to be also backed with adequate human resources and financial resources. So you can have grandiose plans, but if you do not have the human and financial resources to implement those, things are not going to change. The more complex the challenge, greater the need for change management. And this is something which needs equal attention to beyond providing funds and beyond providing human resources. Quality systems are critical to all this. Over the last 6-7 years, the electronic health record system that the government of India wanted to push since 2013 has practically made no dent anywhere except in a few private hospitals. In the governmental setup, the systems are woefully inadequate. And I don't think I'm particularly impressed even with what exists, which is patchy, even within the All India Institute of Medical Sciences, New Delhi, which is clearly one of the leading hospitals in the governmental sector to which people look forward to, and which, having been trained there and having enough context, even today, one can say that one has a reasonable understanding of how things are in that place. So we are therefore looking at a vision which is excellent, which is world class, but I, as of now, see the pronouncements from 15th of August this year on the ramparts of the Red Fort as a indicator of the direction in which things need to go. Looking at the plethora of similar announcements over the last 45 years, the proof lies in the pudding. The performance has always lagged far behind what has been promised, and I don't see how things will be any different anytime soon. So that is my take if I have to comment on it. There was a talk at one point in time that apart from the National Health Authority, there would also be a National Electronic or E-Health Authority, NEHA. Now that has quietly been buried, just like the Disha bill was quietly, unceremoniously, I would say, abandoned by the Ministry of Health and Family Welfare when they left it to the Ministry of Electronics and IT to subsume it in the PDP bill. There was no effort made to ensure that the minimum provisions that could be assimilated into the PDP bill were made to happen. Of course, there were fundamental issues. The Personal Data Protection Bill looks at data from a totally different perspective, personal data from what the Disha bill was looking at. Disha bill wanted the citizen to be the owner of the data. The reality around the world is that in 99% of the countries and in 99% of states within a country like the United States, there is no real concept of ownership as one would like to define it legally. So we are, as patients, at best the originators of information. Personal data is one kind of information that originates from us. But that information gets into the hands of the doctor, the hospital, and the hospital adds value to that information because it's not raw data. They are applying their mind to that information. They are drawing inferences. They are making conclusions. So there is value-added data, which you could say also belongs to the hospital, even though the raw material comes from you. Using that information for managing patients is certainly, but also managing them at the country level or at the state level is equally important. So what appears to be personal data soon gets anonymized, and anonymization is something which is again never perfect. It is done in a manner in which you call it anonymous for the purpose of the law, and therefore you are able to use it freely, whether the government or the private sector. So the reality is that in the digital era, data is the raw material out of which, if you are able to draw inferences from the basis of which you can act to improve things, so much the better. But any information can be put to good uses and bad uses. And therefore, while we are worried about privacy and security, these are two different concepts. Data protection is very distinct from data privacy. Data protection is that you don't want data to get into wrong hands. Data privacy is that you should be controlling access to your data. Now that is never really going to happen, because the moment you anonymize it, you are no longer in control of your own data, even though you know that 2 and 2 can be put together from public sources and from this anonymous data, given the power of artificial intelligence and machine learning in this day and age. That competitive intelligence enables you to draw all kinds of inferences with relative ease, even from anonymous data, the moment you get some markers with which you can plug it. So if you understand this complexity, you know what the government of India is trying to bite is huge. The capability of the government, having been a part of the government, I know is extremely restricted. The competence within the government, particularly if you are looking at the bureaucracies, I'm not particularly enamored of it, having been a part of it. You can't have a set of brilliant individuals. You need systems which perform. And as a system, I don't think we have ever performed in the manner in which I see systems work in institutions, governmental institutions in Switzerland, as an example, since I'm more familiar with it. So while it may sound disappointing, but the fact remains, at least finally there is a talk of doing these things systematically. And to that extent, I am not pessimistic, just like the telemedicine practice guidelines which have come, which may be deficient in 101 ways, but they are a major step forward to clarify a lot of things. So similarly, what is happening in the last few years in the government of India is very heartening. The reason I'm giving the negatives is that you need to look at all these if you are a good risk manager. So if you don't know the problems, you can't solve them. And if you know the problems, then you can prepare for them. So that is the context in which I would like to conclude. Thank you.
Thank you, Dr. Jaya, for highlighting the need for this risk management. Change management is, of course, essential, but risk management is another aspect which probably we are not all looking at that seriously. Before I go to the next question, I think the audience may go on writing their questions in the chat box as well, so that while you are listening, if you have any questions, you can put it in the chat box. So we'll try to respond to that at the end of our discussion. So next, I'd move to Dr. Rajiv. So now you can expand on your opening thoughts you shared with us, and also after what Dr. Jaya said. So really, how do we go ahead? I mean, what would be the most prudent way? Because I think digital is now irreversible. I mean, because of this COVID-19 digital disruption, the pandemic has been hailed as the chief transformation officer globally. And the disruption is irreversible. A lot has already started, and a lot will never come back to the previous conditions. So how best can we live with them? Over to you, Dr. Raj.
Certainly, digital is irreversible, and we have to go in positive direction to make it all digital. And what I have been trying to work in last 10-15 years is having something in digital data format for individual patients. However, like Dr. Jaya expressed, the broad picture at a governmental level and bureaucratic level, and what are the things and loopholes at that place. What I would like to do is start from a general practitioner's level and move up. So how the patients in India, he said that in Switzerland, within one hospital, he can get access to entire data. Now, what is the practice? Let's start from rural India. The patient goes to a general practice who may not be even MBBS, he may be BAMS or BHMS. He tries some treatment there, then he goes to a consultant or say a city where there is a physician, then he's sent to a lab which is at different location. So laboratory does some tests, then maybe he is required to do ultrasonography, then he's sent to a radiologist, then maybe he has to go for a CT scan, he goes to diagnostic center. So there are many healthcare providers or many players in India who are giving treatment. All of us go to institutional hospitals, but most of the patients, 80% people go from a lower level general practitioner, and as the disease advances, say somebody wants a coronary artery bypass graft surgery. So till the time he reaches there, he has gone through 7-8 people. Okay, and those 7-8 people are the players. Now what this document says is he has to give this ID everywhere, he has to give consent everywhere. and he may not be carrying that document because patient doesn't understand. So he will create a new ID. So is your system robust enough? Aadhaar has got, every person has got 2-3 Aadhaars. That people is there. Now we are going to make a based on Aadhaar or not based on Aadhaar, a new ID. So whether that data of one patient is going to be linked to an ID or not, that is one major issue which I think which needs to be sorted out. And people have not thought about the ground reality in rural India, where people go to a general practitioner who sees 150 patients per day. Is he going to have time to take out the ID for the person? Is he going to time for take out a consent for the person? And then everywhere he has to give consent. No, okay, once he gives consent. Second thing is about withdrawal of a consent. So if he withdraws consent from one doctor and that data is not available to others, then is this record going to be a complete record? So to have the record, a complete record, I personally feel that if the person takes out a digital ID, then consent should be assumed. If he gives the digital ID to a doctor, it should be assumed that he has given consent to the doctor and doctor is able to enter the data. That should be the first part. If he wants to get out of the system, he gets out of completely. He has one paper record with him, he carries it everywhere. The advantage of the data of longitudinal data is for the individual person and for the cross-sectional data is for the society. So now if a person is allowed to give consent to one doctor and not allowed to give consent to other doctor, then some of the data will not be captured into the system. So the cross-sectional part of it will suffer. For example, my mother suffered from COVID. If she doesn't want to disclose it, for example, then that one person is removed from the entire network of COVID. So either the patient should give consent completely or should not give completely. That is what is my basic personal understanding. Then second thing is TPG guidelines were having some deficiencies, the consent issues were there, but still some doctors used it for the simple reason that it was beneficial to them. They did not have to see the patient. They did not have to meet a patient who was likely to have COVID. So it was protecting to them. Now, if this digital policy is not going to protect doctors and put them into difficulty, then I am sure they will not use it. Like you have seen response of IMA. IMA said that this is not required. IMA said that telemedicine is not required. So what is the concern of the doctors who are going to use this? Because they are the pioneers, they are the people who will enter the data. So if they don't agree with the system, with the mechanism, then the entire system will fail. How much amount you spend on it, how much bureaucratic effort you take, how much IT people work, this system is likely to fail. So we have to really work on each and every ingredient of the entire system. And if people are not happy, we have to remove the reasons of unhappiness before we go and do something further. So second thing is anonymization. So anonymization is a technical process. This is responsibility entirely of software vendors. All right. The doctor who is entering data, doctor is going to make submission to the system, is not at all savvy. Now you cannot teach him after he has practiced for 20 or 30 years, you cannot teach him to anonymize data. So what are the standards for anonymization? They should be taken into consideration before certifying a software. Now that certification of software has not been spelled out. We have been asking for sandpit software, sandpit server where we can send data and test out whether we can send it to the server or not. If that is not available as of today, this system is, I don't think, is going to run very fast, and it is going to take a lot of 3 to 4 years time from today, if at all it comes into picture. Thank you.
I mean, when we are talking about implications and what could be the barriers and benefits of implementing national digital NDHM here in India. So this is too early to actually comment on basically the barriers or even benefits, but still there are some anticipated benefits and the barriers as well. So I would just start. I just want to start with some benefits for a positive note. So if we can execute this well, so that there is a disclaimer that if we can execute this well, then it can function as a good database for understanding the disease pattern in the population. There it can also be an opportunity for healthcare monitoring, and can bring different, can bring an impetus in healthcare provision, public health research in India. Also, it can help to recognize the disease treatment history. It can map different disease origin, its spread pathway. Basically, it also can help us to understand kind of different social determinants in health, and demographic correlates basically. Also, it can help in population-based follow-up of patients and identifying kind of health-seeking behavior of the population, which is very critical for public health decision making basically. So these are some points we can say that these could be the benefits of NDHM. So, and there are also some probable barriers and challenges as well. So already two esteemed panelists spoke about this. I would kind of add some points to their thoughts also. So obviously everybody can understand that there is a chance of misuse of public data. So mainly because most of our healthcare is, I mean, last some survey data said that there are 66% healthcare is provided by the private healthcare facility. So here, if we don't talk about the well structured and accessible quality public health system, then there would be chances of misuse of public data by private healthcare providers like diagnostic labs, pharmaceuticals, insurance, and everybody else. Like, and there would be ethical issues, breach of privacy, or dealing with. I mean, there are some disease which actually, have some social stigma, and then how about their, breach of privacy and some ethical issues, and there would be challenge for, ambiguity in the procedure of quality of registration.
Yeah, I think back to you, Dr. Jaya. So take forward from what we have heard so far from the others, what would be your tips for all of us to make digital health go the right way in our country?
I think my way of looking at all this is that we should have pilot implementations in a few states or even districts and make things first work at that level. Or you could go even lower down and take a particular subdivision of a district as the unit for the purpose of planning. So if you are looking at a primary health center, then the first departure that needs to be made is get out of the traditional hub and spoke model for telemedicine and become mobile first. The moment you become mobile first, you realize that if you are planning, first and foremost, you should be planning for those who have feature phones, not smartphones. So if you are limiting yourselves to smartphones, you are cutting off the bottom 400 million people in the country. Only last week one heard that both Jio and Airtel are trying now to get into the handset business, where they want to offer handsets which are smartphone equivalent at 2,500 to 4,000 rupees, which would be a significant reduction from the current 9,000-10,000 range, where you generally get a smartphone which is good enough in the 4G context. But while this may be planned in the next 2 or 3 years, I don't see it happening in 300-400 million people in that same very time frame. So if we are really serious, then we have to find ways to creatively, innovatively find solutions where, while you may send links by SMS to these people, and they similarly can send information to you, where an intermediary comes in. So whether that intermediary is a smartphone user or a laptop user or a fixed desktop user, who could be a pharmacist or some other player, which means one has to now start looking at the entire ecosystem, where the government, the private sector, and civil society must all be active partners in defining the scope and what each one will do. Government will never have the resources and the amount they spend on healthcare is abysmal. Even if you take the social sector spending, it's abysmal. And if you are looking at the demographic dividend from any perspective, as it is, we have run out of time. We'll probably age before we become prosperous. And therefore, the demographic dividend will probably disappear before it even gets realized in any meaningful way. And COVID has not helped matters. So, given this strange, challenging circumstances, it's very nice to talk of semantic interoperability. But for that, you must have data first. And the data must not be in silos. And semantic interoperability means things which are far too complex for the ordinary folks when we start talking of ICD-10 and soon ICD-11 or SNOMED CT or FIRE and all other international standards affecting medical devices, because we are now talking of a day and age in which it's not simply WhatsApp messages which are sending information to doctors, which is what the current situation is when you are talking of digital health. Real digital health would be when you have the true Internet of medical things in place as a subset of cyber physical systems. Now, these are concepts which 99% of Indians are not even heard of. And even planners are at the conceptual level, barring a few ministries, quite ignorant, which means I am not very aware whether the Ministry of Health and Family Welfare is looking at this. The Department of Science and Technology, yes. CSIR, yes. But is the CSIR looking at it? I doubt it. So there is so much of law built into it when you are talking of data protection versus privacy. There is an interface with technology, and then there is the interface with standards, terminologies, ontologies. And each of these has a distinct human resource component, training component. So each of these have to be planned. You cannot simply put in place a national digital health blueprint or a national digital health mission and make a grandiose announcement from the ramparts of the Red Fort without any of these things being put in place. I mean, the Arogya Setu app, while on one side it is lauded as a breakthrough in claiming what it seeks to do, but I was reading again in the press that enough states are not quite happy that it is delivering what it is expected to deliver. And in any case, it's a top-down approach to management of health data, which means the person whose information is being collected gets to know very little, almost a residual. He is not being put in place in charge of the information so that he becomes the center of it, who controls as much of it as he needs to be becoming citizen-centric or patient-centric. So a true system in a democratic environment must necessarily be citizen-centric, and citizen-centricity requires thinking of the poorest of the poor. So that thinking I don't see. The National Health Policy of 2017, the e-Sanjeevani system that has come about, has completely divorced itself from the mobile field. And future of digital health is in mobile technologies, where you have to reach people in their homes. And reaching people in their homes critically is dependent on the access to the net and the telecommunication networks. The telecommunication networks are creaking even in Delhi. I mean, in my own house in South Delhi, I just cannot get, whether I try fiber optic cables of Jio or of Airtel, I don't get what I used to get routinely in Geneva without a problem. Even outside the house, if I'm on the street, I'm not certain whether my 4G phone will really deliver. If I'm in a vehicle driving down any major artery of Delhi, my signal is patchy. Imagine, therefore, the plight of people in remote rural areas, in hilly areas. I was in Arunachal a couple of years ago, in the district where once upon a time I was the deputy commissioner, the Dibang Valley. In the foothills of the Dibang Valley, 2 years ago, it was impossible to get a signal of a mobile. And these are populations which also need to be served. After all, health needs are urgent and important, and they need to be met all across. And currently, I mean, the system for all practical purposes is dependent not so much on the so-called the modern system of medicine, because for all practical purposes, it doesn't exist in rural areas. The rural areas have self-styled doctors, which we call self-styled doctors, but in terms of rendering service, they seem to be doing a better job than the so-called formal doctors. If they were not doing their job, I know they create a lot of problems, but they also solve a lot of problems. And if they were not solving problems, they could not have existed. They are solving a market-based need, whether urban slums or remote rural areas. So instead of treating them as a part of the solution, we have always treated them as a part of the problem. And even when it comes to digital health, they can very well be an important part of the solution. So thinking outside the box is critically important. I coming from the modern allopathic system, I do not wish to ignore this informal sector, health sector, and certainly not the Ayush sector. So borrow the best that we have in all systems of medicine. Otherwise, your planning is in silos. Your concept of what is a standard of care cannot be defined in the allopathic system and then transplanted to the Ayush system. And within the Ayush system, it's not one unique thing, Ayurveda, Siddha, Unani, and others. So no thinking seems to be happening. Two ministries deal with two different things and three different boards, but with no common thinking. One set of telemedicine practice guidelines are mechanically adopted and used by Ayush and by Unani systems. Is this the way to make policy? And this is what is happening all around. It's a hurried, cut and paste kind of job. So things must get serious if things really happen.
Thank you, Dr. Jaya. Actually, very well said. In fact, one or two things about the policy part. I think Niti Aayog is looking at the artificial intelligence and Internet of Things as far as policy making is concerned. But then, as you rightly said, it's a top-down thing. So the National Digital Health Mission, currently, they are looking at the connectivity issues, and so they have also started an offline mode. So it's not that you have to be always have to be entirely online. They are taking the ground realities into place. So of course, how much it can be stored and forward of the olden days, we have to wait and see how well does it go ahead. Coming back to Dr. Rajiv, I mean, you also stressed on the importance of data, and I think without data, we can't really think of better health outcomes of patient safety, patient improvement, anything. So how do you think the doctors can be encouraged to collect data, particularly digitally way? The other way, of course, some of the data would automatically go through the Internet of Medical Things, but how can we encourage the doctors to collect data or make others collect data, Dr. Rajiv Joshi?
Yeah. First, I would like to say that instead of an approach of punishment in everything that government does, create an atmosphere of partnership. We are all together in this. There will be some mistakes, there will be some issues. But if you start penalizing doctor for everything that he does, and there is a data breach, there is any problem, whatever government does, you see, it comes with a statement that if you do this or else we will do this. For example, in this COVID epidemic, doctors are being told that you do this, else we'll cancel your registration. You say that is not how things will work. Things will work if you make partnership with them. One more thing I would like to say that, for example, Dr. Jaya was saying that use of SMS. 10 years ago, I developed a system for vaccination reminders, antenatal care reminders, breast examination reminders, and I have been sending through my practice as well as 10, 15 doctors in my area for using it till today. We went to corporation 10 years ago, and they said that we want immediately a system which will generate birth certificate in 3 days. Okay, this was discussion in 2010. Today is 2020. Till today, birth certificate is issued 21 days after birth in Pune. So we have to train the medical administrators in all the government systems, public health systems, about the use of information technology. What can IT do? What can IT not do? How it can be utilized for the best possible utility. Once they are trained, they will start imagining how it can be used. They are the people who are working on ground. Let them decide. Don't decide from the top that you do this. Take a health ID number and connect data to that health ID number. It will happen gradually. Why not linking to Aadhaar card? Aadhaar number is there. You are spending more resource again on creating one more ID. So if you can connect it to only Aadhaar, probably problem is solved. So I mean, these things should be considered by the government. I think time is very short now, so I'll stop here. I can go on talking forever, but I think this is more than enough. Thank you.
Thank you, Dr. Rajiv. I think we are running short of time, so we'll skip the question answer part. So I'll come to Surupa. So what's your overall impression, your concluding remarks? Then I'll come back to the others also for their concluding remarks.
I'm a bit optimistic regarding the NDHM implementation. But yeah, there are some concern which I guess again we need to talk about. I like the idea of sub-district piloting of the project, because yeah, that is, I also agree that you need to start with small and then you can think about scaling up, because in the small piloting projects you can understand and also innovate different kind of things which can be scalable later on. And yeah, I mean there are issues, there are problems. Main thing I guess EMR should be emphasized more and more, because if we really want to happen the digital health mission all over India, all over our country, then there is no other way skipping EHR and EMR. So before even thinking about interoperability, we have to think about the digitization of the data. Then only we can think about the interoperability. So yeah, that is my take on it.
When we go forward, I will certainly feel that use of Nodal City HL7 and ICD-10 will have to become priority instead of asking doctors to collect PDF documents. But as I said earlier, doctors are very apprehensive about the entire NDHM system. And unless and until our concerns are taken care of, I don't think so that doctors will be happy to contribute the data of the patients. Thank you.
So it is not only the stick, but carrot and stick. So incentives and disincentives both should be used judiciously. So I'll come to Dr. Jaya for the concluding remarks. And one interesting question is there from the audience. So I'll ask Dr. Jaya to just briefly talk about it, include in his concluding remarks. I mean, how is data literacy and digital education awareness going to be spread across the nation so that digital health is actually adopted to properly? So over to you, Dr. Jaya.
Let me also add to the list of issues beyond what Sarupa and Rajiv have said. Let us assume that the problems they have mentioned have been solved. Now you still have at best raw digital data. Raw digital data needs to be cleaned before it can be put to use. So cleaning data is a massive job by itself. I mean, even if you assume that it is semantically interoperable, which it is. So clean data then needs to be modeled either through our own models or by use of artificial intelligence tools to derive meaning from it in real time. So the real value of that is that you are able to use big data for data analytics using graphic processors in parallel, and people to then in real time do a lot of things remotely. Now, these are conceptually all possible, but if the interest of the not just the doctor but other functionaries in the healthcare system and beyond the doctors, there's a whole range of people who are involved in healthcare, not just nurses, not just physiotherapists, dentists, but plethora of other categories of professionals who are part of the system, who are also making data entry things. So, and of course, at the end of the day, it's the patient. And increasingly, IoT devices are generating now so much of data that it could well be that the EMR is not the primary repository of information of a person's health. It may well become the secondary repository, and the personal health record then becomes the primary repository of health data. So The current thinking and planning, which is focused on EHRs or EMRs, tends to almost forget the PHR part, and also almost forgets the visual and other challenges that people have, which means web accessibility itself is a challenge. It's not exactly built into the scheme of things. Beyond that, then you come to the issue of literacy. And then, of course, only thereafter you come to the issue of digital literacy. So you have a series of issues to contend with. And digital literacy is something which is a challenge. After all, if devices are not there, then how do you impart digital literacy? So again, you need NGOs to come in and then find ways where one single computer can be used, one single handset can be used by a multiple set of people. And there are good examples in the private sector, in the NGO sector, where startups are doing phenomenally good work, even when it comes to digital literacy. And digital literacy then also has to be in the local language of the state, of the people, in the dialects, which brings in another level of complexity when it comes to use of data or drawing meaning from it, which means the translation challenge. Now, machine translation is something eminently possible. But as you can see, there are layers and layers of issues to be contended with, and each is not entirely in the control of one entity. And therefore, there is a massive need for experimentation in smaller chunks, and multiple experiments will all find solutions in their own ways in different places. So a one-size-fits approach cannot work. A top-down approach has inherent limitations. A bottom-up approach is inherently superior, provided there is partnership and where everyone feels that it's a win-win for them. A long answer to a small question.
Thank you, Dr. Jaya. I think I'll cut off here because I think we have really run out of time. So one of the things NDHM is looking at is federated PHR, federated personal health records, although whether that's the ideal way to go forward or not is still debatable. The other thing which they've done is they've opened a sandbox. The National Digital Health Mission sandbox is there. People can apply and try their products or solutions and to see how it can be integrated. So lots of things are going. May not be in a concerted effort, but I think it has been definitely a very good beginning. There's no doubt about that the first step has been laid. The journey of 1,000 miles always begins with a single step. So we can look at it that way, that the first step has been taken. Now we are all together have to ensure that the other steps are also taken in the proper way. So I thank all of you again for a wonderful interactive session, and we hope to talk at length at some other time again. So till then, goodbye and take care.
For more updates from CXO TV, please like and subscribe to our channel.